Hello, good afternoon. Today we're going to talk about one of the most important topic in gastroenterology called inflammatory bowel disease, which people call this condition with various other names, as you probably know, because they call them with colitis, ulcerative colitis, Crohn's colitis, and various other things. So what we're going to learn today about this condition was to primarily see why do we get this condition, what is inflammatory bowel disease, why do we get it, what are the common symptoms, how can we manage this condition. And I'm going to give you a few examples of my patients who has gone through the process. So inflammatory bowel disease is a very, very common condition, and it used to be very common in the Western world, but it's become very common even in Eastern countries. It's a type of inflammation affecting the bowel. If it purely affects the large bowel, it's considered as ulcerative colitis, or if it affects right from the mouth to the anus, it's Crohn's colitis. Again, the depth of the walls vary, the involvement of the disease varies from Crohn's to ulcerative colitis. That's the big difference. And what are the symptoms that you get from ulcerative colitis or Crohn's colitis? The common symptoms most patients present with is diarrhea. They have loose stools. Often there is bleeding because there are ulcers, and they get tummy pain as well. They tend to lose weight, they feel tired, and they get iron deficiencies and various other factors. People with Crohn's also develop fistulas and fissures. What's the causes for these inflammatory bowel disease? The causes for the inflammatory bowel disease are multi factors. It includes genetics. If your parents has inflammatory bowel disease, you have 1 in 5 chance of developing the disease. Autoimmune conditions, where your own immune system fights against your bowel. Or environmental factors, for example, Crohn's. People who smoke has high risk of developing Crohn's. And there are diet issues, and the latest scientific evidence shows that all this develop because there is a change in the bacterial lining of your bowel that triggers this type of scenarios, called microbiome. So, ulcerative colitis, it mainly affects the large bowel. Sometimes it only affects the tail end of your large bowel, called proctitis. In this group of patients, they mainly present with urgency, where they want to run to the toilet, they want to run now. And they also have a lot of bleeding. This group of patients, we can treat them effectively by medication that's delivered locally by putting the medications in the back passage. Or it can affect multiple areas of your large bowel, right side, left side, or pancolitis. And they come in different severities. They come as mild ulcerative colitis, moderate, or severe. So severe ulcerative colitis, where the symptoms are so bad that they have to go to the toilet more than 10 times a day, or the bleeding quite a lot. The bean look unwell, the malnourished, tummy pain, bowel look distended. These are the patients who need to get admitted to the hospital, and they need intravenous fluids, steroids, and antibiotics. The mild cases need oral medication, for example, mesalazines. Moderate sometimes need steroids to suppress the disease and then leave them to remission. And then we give the various other medication depending on how often they're getting recurrences. For example, if they need multiple episodes of steroids, we put them on steroid sparing drugs called azathioprine or 6-mercaptopurine. The reason is that the long-term steroids are not good for health. Again, if the disease is not controlled, we go into the higher dose of medication called biologicals. Crohn's colitis, again, can affect from the mouth to the bottom end, and the disease can be mild or severe. Unfortunately, the Crohn's patients tend to have more surgery requirement compared to the ulcerative colitis. Around 50% will have some sort of surgery within 5 years of the diagnosis. The whole idea of diagnosing early, treating them early, managing them early is to prevent surgery. So generally, when we talk about treatment, we talk about step up or step down. Either you consider giving biologicals, high powerful drugs to completely suppress the disease. Once it's suppressed, we give them salicylates to maintain the low, suppress the disease. Or we start at the lower dose called salicylates and then give steroids and then go up the ladder called biologicals. A lot of patients ask me, what about the diet? Scientifically, there is no correlation to the diet to trigger the colitis, but ideally we suggest patients to have low residue diet because they don't need to have obstruction, less carbohydrate diet, more of a protein diet is useful. The IBD patients do have extra intestinal problems, so that means not only just affecting the bowel, it does affect the other parts of the body. Example, arthritis, or they can have red eyes called iritis, or back problems. These are extra intestinal manifestations we need to look for. How do you diagnose inflammatory bowel disease? There are various ways. We do a blood test, specifically looking for blood markers for inflammation like CRP, ESR. Or we look at the stool examination called fecal calprotectin. Most of these patients do need examination for infection in the bowel. To confirmation point of view, they need a colonoscopy, where we put a tube down the large bowel, take some biopsies, look for inflammation, and confirm whether they got Crohn's or ulcerative colitis. And majority of the patients do need surveillance because these patients are high risk of developing cancers, not only in the bowel but also in the liver. This is in a nutshell about the inflammatory bowel disease. Has anybody got any questions? Any questions? No questions. ఇంకేమైనా మాట్లాడాలా? ఎంగేజ్మెంట్ ఎంతమంది ఉన్నారు సార్? లెగ్ క్లోజ్ చేసి